Hello, and welcome to part 2 of migraine management for the otolaryngologist, More Than a Headache, a part of the American Academy of Otolaryngology virtual annual meeting, year 2020. I am co-presenting this course with John Carey, and if you were in listening to part 1, we reviewed the epidemiology and pathophysiology of migraine and followed it with otologic manifestations of migraine based on some physiologic evidence that the inner ear can be directly affected by migraine mechanisms. That is to say that the blood vessels of the inner ear are innervated by unmyelinated branches from the first division of the trigeminal nerve, which contain inflammatory peptides, which when released may actually cause otologic disease. We discussed vestibular migraine, which may have manifestations solely in the brainstem and may create symptoms which can only be created in the brain but not in the inner ear. We discussed Meniere's disease, which may be a complication of migraine in susceptible individuals. And that was where we left part 1. We're going to start part 2 with a review of the relationship of BPPV and migraine, tinnitus and migraine, and even sudden hearing loss. Then we're going to discuss some sinonasal manifestations, and we'll discuss treatment of migraine. So, migraine and benign positional vertigo. For uninitiated, the notion that migraine and BPPV could be related may seem far out, but we feel that there is a significant evidence now relating migraine and benign positional vertigo. Migraine is 3 times more frequent in idiopathic benign positional vertigo than in BPPV secondary to head trauma or surgery. Migraine is 2 times more prevalent in patients with BPPV than in age and sex matched controls. And overall, the odds ratio for BPPV in individuals with migraine is 7.5 over age and sex matched controls. These are significant correlations. There's a general female to male predominance of migraine of 2 to 1, but when we look at recurrent BPPV, the incidence is 3.2 to 1, and this maximum occurs at menopause. This is a large study reviewing 1,300 BPPV patients. There was a very high rate of female to male prevalence of BPPV in the teenage age group related probably to puberty, but the numbers here are very small. So can migraine actually cause BPPV? Well, the thinking is that plasma extravasation or other peripheral inflammation could damage the utricle if this is related to migraine. So the vascular supply of the labyrinth is really a portion of the intracranial vascular supply. It shares the same innervation, the same inflammatory peptides, and migraine is variable in its manifestations. And the locations which are affected. So if the inner ear happens to be a domain that is regionally affected by an individual's migraine, then perhaps intralabyrinthine damage could occur. So we know that recurrent BPPV and migraine definitely is associated, and especially true in young patients. If you see a very young patient who has BPPV, with confirmed eye movements and positional testing, then it's most likely that it is a complication of migraine or trauma. This patient has a history of recurrent migraine. We're not going to play the entire clip, but her history is that she had many episodes recurring over the years, 2 to 3 times per year. Her physical therapist was adept at curing her episodes with an Epley maneuver, and then she remained symptom-free for months until the onset of a new episode of BPPV, which in her case began with a large migraine headache episode, usually a 2-day-long migraine that was simultaneous with the onset of her otolic disease. She also had ear fullness in the right ear, which was the side that was affected both by the headache and with the BPPV. And she was treated with low-dose nortriptyline. And not only did the ear fullness go away, but the recurrences of BPPV had stopped as well. I've looked at 500 consecutive patients who have presented to my vestibular clinic. And in those 500 patients, 212 had BPPV, 236 had migraine, vestibular migraine, and 169 had migraine. But many patients had 2 of these problems, and some even had 3 of these problems altogether. So when we look at the number of vestibular migraine patients who have BPPV, the percentage is 22.4. This is much, much higher than the prevalence of migraine in the general population. This is much higher than the prevalence of BPPV in the population. When we look at the patients who have BPPV alone, and we look at the number who have migraine, 28% have migraine. Remember, the population prevalence in the United States of migraine is only 13%, and this is more than double that rate of occurrence. Now, how about tinnitus? Tinnitus is one of those problems that we see a lot of, and we have generally been taught that there is no evidence that anything works for tinnitus, so don't give patients false hope. I believe that these notions are limiting, and that there is a subgroup of patients who have tinnitus which may be related to migraine who may be served. There is, in fact, evidence that there is some distinct correlation of the laterality of tinnitus and migraine, and that tinnitus is much more prevalent in patients who have headache. So in our population study that we presented early in part 1, over 70% had tinnitus of the migraineurs that were identified in otolaryngology offices. In this tinnitus clinic, 44% of the patients had migraine. This is much higher than 13% in the general population. And about 43% reported that their tinnitus worsened with a headache. Now, how could that possibly be possible? Well, it's because that it actually may be possible that central firing of auditory neurons is increased during a migraine episode. Remember, the central nervous system of an individual with migraine is sensitized. So symptoms of any sensory input can be enhanced when a migraine is active. So more important than all of this is that the tinnitus in these patients responds to migraine management. So in my clinic, if I see a patient who has tinnitus, which changes in intensity or in character, rather than being a constant low-level tinnitus that only changes because there are differences in the amount of ambient noise, then I recommend a treatment with migraine preventive medication, whether or not headache is present. And you would be surprised at how gratifying it is to see patients who have never been treated for tinnitus have been told that there's nothing that can be done for tinnitus, and then who have a relief of their tinnitus with treatment. Now, the tinnitus doesn't always go away, but if it's fluctuating, it tends to stabilize at the low end of its fluctuation. And because the tinnitus becomes stable, it becomes more tolerable. Patients with tinnitus even get, patients with migraine even get pulsatile tinnitus. Approximately 1.9% of migraineurs will not only have tinnitus, but pulsatile tinnitus. And in one report of Dr. Carey's, the 11 of 16 patients had resolution of their pulsatile tinnitus with migraine management. How about sudden hearing loss? If all of these vascular changes are occurring in the inner ear, is there any evidence that sudden hearing loss could be a migraine a phenomena rather than an idiopathic or a viral phenomena? Well, this good study demonstrated had patients who were treated with steroids and intratympanic dexamethasone, and another group of patients treated with steroids, intratympanic dexamethasone, and migraine medication, medication and lifestyle changes. And there was a pure tone average improvement of 78% of the patients who received the adjuvant migraine therapy compared to only 46% in the control group. So there you can see the change in decibels that with much bigger levels of change in the patients who received migraine management plus intratympanic dexamethasone. Now, symptoms of migraine can be very variable. And in fact, they can vary in an individual over the course of a lifetime. Headaches may become much less severe over time, and they and a patient who had classic migraine in the past might just have a dull ache or a pressure in the head now. They may even consider that their headache is gone and answer the question, do you still have headaches, with a definite no. But then on further questioning, you discover that they do have a mild headache. It's just so different in intensity that they don't consider it a headache any longer. Instead, what brings them to the doctor are these secondary neurological symptoms that behave like migraine, but are not associated with a debilitating headache. When we talk about debility, what we're talking about is the inability of patients to do things that they need to do, that they want to do, and that they said that they would do. This means that migraine is really impacting their reliability. And it's very difficult, especially a large number of migraine patients are suffering of this in the most productive years of their lives. Now, the IHS criteria, which are research criteria, are not really flexible enough to encompass all of the patients we're likely to see as otolaryngologists. So we have to be careful about using migraine criteria as exclusion criteria for treatment inadvertently, and be more inclusive in our thinking. If it acts like a migraine, then perhaps you should do an empiric trial of treatment. Now, let's pivot away from the inner ear and the brain and toward the sinuses. It was, in fact, here's where we want to make a distinction between actual sinus headache, which is a headache which we feel in the region of the sinuses, and a rhinogenic headache, a headache that occurs because there is a pathologic process stimulating nociceptors in the sinuses themselves, such as a chronic sinusitis. So sinus pressure was identified in the American Migraine study, the largest epidemiologic study done in America to date of migraine, as very common. 75% of the undiagnosed migraine sufferers, and only half of them had received a diagnosis, were given other diagnoses. And most of the time they were told they had either tension type headache, 32% of the time, or 42% of the time, more commonly, they were told, oh, you don't have migraine, you have sinus headache. And and the prevalence of sinus headache was found to be 15% using that history compared to migraine, which is 13%. Well, it turns out that sinus headache is migraine, but affecting the second division of the trigeminal nerve. Now, it's hard to undo preconceived notions about headache and sinuses. You know, as physicians, we always think about nasal and ocular symptoms as being uncharacteristic of migraine because the IHS criteria don't talk about them, and we learn about migraine in medical school. But the IHS criteria were created by neurologists who do not list these symptoms as criteria for assigning a diagnosis of migraine. The patients themselves may conceptualize nasal and ocular symptoms as sinus because they're confronted with advertisements with patients who have glowing red sinuses on animations and TV commercials and in print media. And they associate the pounding pain of those symptoms, not with migraine or as sinus headache even, but as it must be infection. And when we learn that decongestants work, we say, well, maybe it really is just a sinonasal problem. But a decongestant is like a mild triptan. It causes vasoconstriction and will help a migraine headache. In fact, some patients with migraine identify 12-hour Sudafed as one of their go-to savior pills for migraine headaches. A lot of patients with sinus headache, they are sensitive to weather change. And we always think about this as being associated with sinus headache, but we know that patients with sinusitis don't have weather change sensitivity. A lot of patients get better, at least temporarily, with surgery. And so how could it be anything else if they get better with surgery, if we open the ostia? Well, it may be that there are some reasons for that, and it may be that we're denervating the nose in the area of the osteomeatal complex. But the free nerve endings, which innervate the osteomeatal complex, grow back, and the patient can have perfectly normal appearing sinuses and well healed, but then their headaches resume with no exudate, no mucosal dysfunction, no pooling of secretions, no allergic changes. So overall, up to 50% of migraine patients say that their headaches are influenced by the weather. 45% of migraine patients report that when they get a migraine headache, sinus symptoms are present, including lacrimation, rhinorrhea, and nasal congestion. And all of those are associated with increased activity in the superior salivatory nucleus, a part of the increased parasympathetic outflow that is typical of migraine disease. And also, migraine is always thought of as a unilateral problem, and often sinus pressure is bilateral. But migraine is actually bilateral in up 40% of patients. The study that really rocked our world in terms of migraine management was that of the American Migraine, was a study in which self-identified sinus headache sufferers were examined by a neurologist, an otolaryngologist, and an allergist. And they were all given headache classifications based on the diagnoses. And it turned out that only 3% of those patients had headache that could be attributed to rhinosinusitis. A full 97% had classifiable and identifiable types of headache. And so 54% of patients with self-reported sinus headaches did not have any findings of sinusitis on endoscopy and CT, and 73% met the IHS criteria, but 82% of the group had a response of sinus headache to triptans. So this is a first paper documenting the response of sinus headache to triptans. Another study demonstrated the responsiveness of sinus headache to valproic acid. There was a 71% response at 3 months in patients with chronic sinus headache. How about allergy and immunotherapy? Are they related to migraine headache? Well, patients were followed, and their testing put them on a scale of a degree of atopy, and there was a direct correlation in this group of 530 patients between the degree of atopy and the frequency and intensity of their migraine headaches. And when in the patients who were under 45 years of age, immunotherapy was successful in significantly reducing migraine frequency and disability. When we look at serum IgE among migraineurs, we can see that non-allergic headache sufferers have they have higher serum IgE than controls, but not as high as allergic patients. When we look at the patients who have serum histamine in migraineurs, when they don't have pain, their serum circulating histamine is higher than controls, but when pain is present, their histamine soars. And what is the cause of this? We think that histamine levels increase during migraine pain because when inflammatory peptides are released from C fibers, it causes mast cell degranulation. And mast cells are in all tissues in the human body. Mast cells are even in the central nervous system. So we think that this is one reason that stabilization of membranes and prevention of histamine release is an effective treatment for many patients with migraine. So we know that allergic degranulation of mast cells can stimulate these afferent fibers and cause pain. And we know that many patients respond to immunotherapy. There are some patients who do very, very well with allergy therapy. So when we look at a FES, when we think about FES, why do our patients respond only temporarily in many cases to surgery, and sometimes they respond permanently? That is because probably there is a denervation of the most heavily innervated area of the osteomeatal complex of C fibers from the second division of the trigeminal nerve. And when we take those away, then the nose is not as susceptible to the effects of central parasympathetic outflow changes and not as susceptible to the release of neuropeptides. It's kind of a surgical nerve block, but free nerve endings that don't have a specific receptor can grow back. And if they grow back after surgery and become active again, then we can have a return of symptoms in an otherwise perfectly surgically treated patients. These patients are fun to operate on. They don't bleed. So it's fast and anatomic in the dissection. They have minimal changes on CT. These shots show an osteomeatal complex with no headache, with a moderate to severe sinus headache, and then after taking a triptan, you can see a significant decongestive effect. So how can you tell if it's migraine or sinusitis? Well, the congestion and rhinorrhea is only present in a migraine at the time of a headache, and it's triggerable by common migraine triggers that can be physiologic, environmental, or dietary. In a patient who has chronic sinusitis, the congestion and rhinorrhea tends to be perennial or seasonal, but it does not have any triggerability. Both groups of patients have facial pressure, of course, and but the symptoms in a patient who has rhinosinusitis are persistent and last for days, whereas a patient who is suffering from sinus headache may have symptoms which just come for hours, pass, and then come back again. Of course, if you only have a sinus headache without infection, you have no infected drainage compared to a patient with chronic rhinosinusitis who does have infected drainage. And many of our patients have taken so many Z-Paks for their non-infected sinus headache. They have just come to believe that, well, I never get infected drainage because the Z-Pak nips it in the bud. They don't call an otolaryngologist, they call their primary care physician, and a second level provider, a mid-level provider calls in the antibiotic, and this reinforces their notion that this is an infectious problem, when in fact their problem was going to go away on its own. There are no mucosal changes in most migraineurs, although there can be distinct vasomotor or allergic changes in patients with chronic sinusitis. The CT scan in patients with migraine or sinus headache is usually normal compared to distinct abnormalities in a patient who has migraine. Both groups will respond to decongestants. They'll have a symptom improvement, and the improvement will come from direct decongestion of nasal membranes, but also because of vasoconstriction and pain reduction based on vasoconstriction of sensitized vessels in migraineurs. And a patient who has sinus headache that's recurrent can prevent their headaches by spraying substance P blockers like capsaicin into their nose. This is sinus buster spray, if you're not familiar with it, that's available over the counter. And by spraying capsaicin, you induce inflammatory peptide release, and then with time you empty out your C fibers, and then the effect of pain is diminished. But this doesn't work for patients with sinusitis. So to be sure it's migraine, we must maintain a high degree of suspicion in any patient with chronic and recurrent facial or head pain, if they don't have any structural lesions to explain it, and if there are if there are associated neurologic symptoms. Like imagine the patients who have sinus headache, but they also have vertigo, or they also have aura, or they also have otalgia or numbness, or nausea. They often don't have a response to the usual therapy, and their symptoms may be triggerable, just as a migraine headache is triggerable. They may have a past history of migraine, and they think that their symptoms, their migraine is gone. But you need to explain to these patients that this is a genetic predisposition that is lifelong, and there are different periods of their lives when they may exceed their threshold for migraine and require preventive management. So it's not unusual for a migraineur to go through 1 or 2 periods in their life when for a few years they benefit from treatment. So these patients also tend to have a family history, and it's not too unusual for you to hear that, well, everyone else in my family got migraine, I'm the one who didn't get it. And in fact, they did get it. They just are getting their own personalized version of it that they are not recognizing. So how do you treat sinus headache? If migraine and sinus headache coexist, empirically treat migraine as well with preventive treatment. If allergy is present, treat allergy as well. It can really help. It's one of the triggers which adds up to put a patient over their threshold. If migraine is suspected, you can try empiric therapy at least before surgery, and you can even prescribe a triptan, like sumatriptan, to see if it is successful in aborting their episodes of pain, and then you can consider prophylaxis. So the patient may not only lose their sinus headache, but they may be having other migraine-related symptoms which disappear, but which were not a part of your interview, and so were not reported to you. So let's take a look at how we're going to treat these patients. I believe migraine management is something that is so important in the otolaryngology clinic that it is going to enter into the general curriculum for migraine over the next 10 years. There are certainly not enough patients who meet criteria for migraine that our neurology colleagues are going to take care of these patients. And migraine management is easy. We only need to manage with a few medications to get great results. The most important thing, though, is to get a buy-in from your patient. You know, the patient has to understand that migraine doesn't equal headache. Migraine is a lot of different manifestations. And we have a handout which is a part of your downloadable PDF, and it has the handout that we use to give to our patients. And this is very important in enrolling patients in the project of their treatment. So they need to understand that headache is certainly the most common manifestation, but not the only one, and that all of these other possibilities exist. So in general, we have an idea that migraine may be present. That's our hypothesis. Now we want to test the hypothesis with an empiric treatment. I show patients a graph just like this and show them that the triggers are partial triggers, and they add up in different ways on different days, and that their threshold is low and they have lots of symptoms. And the medications we're going to give them are going to push thresholds up. And, but we're also have an ability to reduce triggers. And if we can do both, then they will be effectively treated, have intermittent symptoms, and they may even be able to tell which are the triggers that are most important to them and which push them over their threshold most commonly. So there's a certain amount of education that's necessary, as well as teamwork. You have to both get on the same page. So trigger identification and avoidance is important for many patients, and some patients who just have occasional symptoms 3 or 4 times a month can get by with pseudoephedrine or abortive medications. Excedrin migraine is a combination of an analgesic, aspirin, and caffeine, and is a quite good migraine medication. Of course, if you take caffeine every day and several times a day for more than a few weeks, you'll get a rebound, and you can get rebound headache. And some of the patients you'll meet, they'll already be having rebound headache. There are abortive agents like Imitrex that you can, or sumatriptan, which you can start with as well. But most of the patients with atypical symptoms will need migraine prophylaxis. And you'll end up with some combined therapy. They'll have a great reduction in their episodes with prophylaxis, but they'll need something when their symptoms do break through from time to time. Of course, lifestyle improvement is a big part of this. We talked about in our physiologic triggers how stress and fatigue and hunger and dehydration all push migraine, and you can have better sleep hygiene. You can reduce stress, you can exercise, you can avoid dehydration. And this is very effective and important for many chronic migraine sufferers. But many of the patients we see with these headaches or other symptoms, they have chronic symptoms. They're continuous for days, weeks, or months. And sometimes we have to break the cycle. And for patients who are having pain, to break the cycle, we use different kinds of nerve blocks or even Botox to break the cycle of migraine. And this can be very effective. And I would say about a third of the patients who get Botox, they don't continue on it long term. The Botox actually breaks the cycle of migraine for long enough that their head, that the preventive medications they're taking start to work better, and then they no longer need the quarterly injections. So trigger identification and avoidance is the first step. It's highly effective even in severe and refractory cases. If there is a trigger, let's say somebody is a severe tooth grinder and their headaches just don't respond to anything, but they have such severe problems that they have TMJ, erosion, and they have bruxism and grinding of their teeth. Well, those patients need therapy on their TMJ. That is the thorn in the paw. That's the trigger that can cure them. Now you can decrease the sensitivity of the central nervous system at the same time, but you're really going to want to concentrate on the focused site of injury for that patient. The same is true if you find a problem in the neck and sometimes in the sinuses. But patients need to keep a diary, and they have to be very motivated to help to try to figure this out in concert with your guidance. Abortive therapies work best, as I mentioned, for episodic migraine. We talked about Excedrin and pseudoephedrine, and then triptans. As disability increases, these non-specific therapies are less likely to work, and the patient is going to need more focused triptans. And now we have CGRP inhibiting GPANT medications, which are very effective, but are new, and not very many people have clinical experience with them. The earlier that you use a triptan, the better, because what we're treating is a chemical spill here. And so it's easier to nip a migraine in the bud, even with ibuprofen, than to try to treat it after it has been established for hours. So you can get some pain reduction, but there is already a significant inflammatory soup around blood vessels in the and increased activity in the brainstem of an individual who has a well-developed migraine. And we, of course, want to be mindful that rebound is a problem. So when you prescribe a triptan, the pharmacist will usually only dispense 9 doses per month to a patient. So these were a great advance in migraine therapy 20 years ago when they came out, and they're serotonin agonists, which have a direct effect on blood vessels. And they were created as vasoconstrictors to decrease pain of migraine. And it was only after they were released that it was noted that they have other effects. And we'll go over those in the next slide. They tend to work pretty quickly, within about an hour. They have pretty high efficacy of headache relief, and most patients get relief and they can continue to work. But some patients feel like that it's inadequate. They will say, I have, my headache goes away, but then I just feel so drowsy that I can't function anyway. And that's not a good outcome. If patients have severe coronary artery disease, then or uncontrolled hypertension, we avoid them. But in general, they are safe. If they were not very safe, we would have a lot. They're so widely used that a lot of people would have myocardial infarction or strokes because of triptans, but we just don't see that clinically in the emergency departments or in any centers. So these are relatively safe. So there are lots of different triptans, but where we knew that they act, that they inhibit some of the dilation of vessels and promote vasoconstriction, which improves pain, it was only years after their release that it was found that they actually block protein extravasation and inhibit neuropeptide release, both in the intracranial and extracranial vessels. And that there were even other effects on serotonin receptors in the central trigeminocervical complex. If one triptan doesn't work, try another one. There is no reason to believe that a single triptan can be a good test for all of them. They have a few differences, and the Maxalt is a rizatriptan, is a very fast-acting dissolving tablet, which is really nice. Some people have a very long acting need. So if you have a patient who only has menstrual migraine, they can take this one every 12 hours during their menstrual period to control their headache, and they don't need it the rest of the month. So a little trial and error is necessary. So most of the patients we're going to see are going to require migraine prophylaxis. And this is if the headaches or the symptoms that we're treating are too frequent or too brief to use an abortive therapy, then we need to elevate the threshold. These are generally well-tolerated medications, and we have to select the medications based on coexisting medical conditions and coexisting medications. It can take up to 6 weeks before you can tell that a medication is definitely working. Usually I'll see people back at 6 weeks to assess the response. I don't like to wait 3 or 4 or 5 months in between appointments, which is typical in neurology, because if the headaches continue untreated or any symptoms continue untreated, well, there's a chronification that happens with neurologic symptoms, and they can become more durable and difficult to treat. So if we don't want that to happen on our watch, so 6 weeks is long enough, and if we decide at that time whether the medication is working, whether there are tolerable side effects, whether we should adjust the dose of the medication or change medications altogether, then we can make those decisions every 6 weeks and navigate within 3 or 4 visits to a point of significant success. So I give my patients an expectation that within the next 6 months, we're going to zero in on something that works for you. And this is, and the goal is not complete elimination. If we can get 50 to 70% that reduction in symptoms, that is a good goal and expectation to give to your patients, because often you will exceed it. And that will result in a very, very happy patient if they get 80 to 90% instead. So we use this kind of therapy as for hypothesis testing in individual patients. Now, the general categories of medications that we use are beta blockers, calcium channel blockers, tricyclic antidepressants, and anticonvulsants. We also sometimes use carbonic anhydrase inhibitors. The primary reason that many of these work is that they're ion channel blockers. And as we mentioned, there is a tendency for inherited ion channel defects in the central nervous system, which creates a lifetime susceptibility to migraine. Now, how do we know what to use? Well, in general, there are some rules here. Generally, these are all well tolerated, but we tend, with beta blockers, as a blood pressure medication, we can't give these at the same time as the patient is taking a calcium channel blocker. How about tricyclic antidepressants? In general, we use these at low doses. So although there is a hesitation to use them when a patient is taking another SSRI, and the pharmacist will say, wait a minute, you shouldn't take this because you're already taking another SSRI. We remind the patient that we're treating them with very low doses compared to psychiatric doses of these medications. We have patients who tolerate anticonvulsants. Usually these don't interfere with other medications. Carbonic anhydrase inhibitors, honestly, are quite rarely used, sort of as a last resort. This may be one of the most important slides in this entire 2-hour presentation. Nortriptyline is a tricyclic antidepressant. It was, if you were a patient with major depression in the 1970s, it's likely you would have been prescribed nortriptyline. It is an SNRI, a serotonin and norepinephrine reuptake inhibitor, but it also happens to be a medium potency sodium and calcium channel blocker. It's also anticholinergic, so it actually has a way of treating migraine in many different ways. So serotonin receptors, sodium and calcium channel blockade, reversal of some of the anticholinergic effects, and on top of everything, all tricyclic antidepressants were manufactured from antihistamines and have some residual antihistamine effect. And if I were a psychiatrist treating depression in 1975, I would start at 100 milligrams of nortriptyline and we would go up to as high as 350 milligrams. But those high doses are associated, and we would need those high doses to get antidepressant effects. But they are associated with a terrible profile of side effects, the same list that they're going to give your patients at the pharmacy. We have to reassure our patients that we're treating them at very low doses, 5 to 10 times lower than the doses used for depression. And by taking only 20 milligrams as an index dose, we can slowly titrate up to maximize their benefit. So when I say index dose, what I mean is that there is hardly a patient who responds to this medication who doesn't respond at least some at 20 milligrams. And if they do respond some, that's when you start to titrate up 10 milligrams at a time until you find the right balance between symptom control and side effects. So what is noticed at these low doses? At these low doses, usually you take it, you can have some dry mouth. You could, over a long period of time, experience weight gain, but generally it would relax you. You take it before bed, and it has a very long half-life. So you can, if a patient sleeps well, that is helpful because some of these patients are sleep deprived. And if they are dragging for an hour or two earlier in the morning, then I encourage them to just take it an hour or two earlier in the evening. Amitriptyline can be used almost interchangeably, the same dosing and side effects, but in the past, amitriptyline had too many side effects. Nortriptyline, which is a tertiary rather than a secondary amine, has fewer side effects than amitriptyline per milligram. So it does come in a tablet. So if you have a patient who's extremely sensitive to it and you want to go lower than 10, and the nortriptyline comes only as a capsule, you have two options. You can prescribe amitriptyline and take a half of a capsule, or you can take nortriptyline 10 milligrams every other day with a half-life of 72 hours. That gives you a serum level of about 5 milligrams. Beta blockers are useful. They were the oldest prophylactic medication. It's an old medication, and not only was it good in hypertension, but patients came back and said, I'm glad my blood pressure is fine. I didn't know whether it was high or low at home, but I haven't had a headache in months. The propranolol is what we use. It comes in an XL formulation, or long acting. We give 60 milligrams a day and go up to 120 after a couple of weeks if there's no good response and if it's tolerated. We have to worry a little bit if patients are depressed because it can worsen depression. Their nadolol gets into the central nervous system a little less, so it can be useful in those patients. If it doesn't work, then you stop it. You should step down to 60 and then off. And a very occasional patient will say, I stopped my medicine, but my heart is racing. That's a reflex tachycardia. And you just say, just take it again and let me prescribe some regular tablets and you can just taper down by halving the dose every couple of days. And in 4 or 5 days, they can get off of it without that. Now, topiramate is something we've all heard about. It's an anticonvulsant and a carbonic anhydrase inhibitor, in both packaged together. It's a single molecule, but it has both of these effects. So it has a sodium channel blocker as the effect, as an anticonvulsant effect. It is quite effective, but and it had a bad name because when it was first released, the dosing to the index dose was 50 milligrams twice a day. Well, if you just start taking that de novo, the side effects are really quite pronounced. But it turns out that if you give 25 milligram tablets and you escalate by 25 milligrams a week to 50 milligrams twice a day, then the side effects are minimized. In fact, the side effects that people experience are numbness and tingling in the fingers and toes. They can notice a change in their appetite, a decrease in appetite, which is really a selling point for many of the patients. But they could also notice a cognitive change that makes them less sharp. And if that is a problem, and it can be for noticeable in about 24%. If it's a big problem, then it's not a good workable solution. But there is a long-acting form of this called Trokendi, and this formulation allows you to treat, and it only has a 4% cognitive side effect profile. So you can get to higher doses without the cognitive side effect and push the response, even if in those patients who have limiting side effects, but good efficacy. I wouldn't use this medication in anyone who is a renal stone former, because the alkalosis that they get from the carbonic anhydrase inhibitor enhances the tendency to form stones. So calcium channel blockers are really very helpful. They're tolerated. We use diltiazem because it's quite long acting. And we go right to 120 milligrams as a starting dose, and we go up higher if we need to. There can be some constipation with it and hypotension, but not in very many people. Patients are often worried. They say, look, you're going to give me this beta blocker or a calcium channel blocker, and my blood pressure is only about 100, or even lower. And the reality is that it's not very common that our patients say, you know, I took this medicine and I can't stand up. I keep almost blacking out. The reason that that doesn't happen is that these patients with chronic migraine symptoms have such increased parasympathetic outflow that their peripheral vasculature is maximally vasodilated. It can't dilate anymore in response to this calcium channel blockade or a beta blockade. So whereas relaxation happens and a good blood pressure drop happens in a patient who has hypertension, there's almost no change in a patient who already has migraine-related hypotension. So in general, this is what I do. Everybody has a different way that they like to do things, but my experience is that if patients over 50 years of age, I start with tricyclics. They're very, very well tolerated. For some people, they come back and say, hey, where has this been? This is like the missing vitamin in my life. I feel great on it. In patients under 50, tricyclics have a higher chance of making them feel tired. So in patients under 50, if they're females, I start with topiramate, and in males, I tend to start with propranolol. And there's something, I feel like I maximize my first hit rate with this, but I have to tell my patients that there's about a 2.3 medicine trial rate. We have to continue to try medicines. Sometimes we get it on the first or second medicine. Other times we're waiting 4 or 5 medicines before we find something that works. So propranolol for men, topiramate, and then if it doesn't work, then we move on to the medication until we try everything. As a second line, I use calcium channel blockers. But sometimes you're limited. If a patient's already taking metoprolol, well, then we can't give them a calcium channel blocker as well. Sometimes we'll turn up the metoprolol. So we'll add, or we'll add topiramate or a tricyclic to it. So therapy is customized. So a good review of this is that we have this genetic substrate that creates a threshold for migraine. And we have this pile of physiologic, dietary, and environmental triggers, which summate in different ways on different days to put us over our threshold. And we can push the threshold higher with medications, and we can reduce triggers as much as they can be. We have the best control over our diet. But sometimes physiologic triggers can be reduced by lifestyle changes, and this can result in really good control for a lot of patients. So they have to do both. So trigger identification and avoidance, followed by preventive therapy, and then abortive medication for breakthroughs. We never give Furacet. We never give narcotics. These cause hyperalgesia. They actually don't make the situation better for anyone. We know that a lot of patients ask us about CBD. There's actually evidence that they work because they desensitize some of the vanilloid receptors, and that they actually may cause a change that makes a migraine less likely to occur. But we don't have enough accumulated evidence yet, and I tell people it's not going to hurt anything if you try it, but I'm not going to guide your therapy with it. So maybe you want to treat migraine, and all of your partners are worried. I don't want to treat migraine. What if I'm on call and your headache patient calls? First, there's no emergency if people run out of their medicine. The only thing they really need to know is if anybody calls and they say the words "worst headache of my life," they need to go to the emergency room. And the only time that you need to get an MRI in these patients is when there's a distinct change in the pattern of their disease, or if there's a functional loss, if they're having nerve deficits. So it's usually unlikely that you're going to miss serious pathology treating migraine patients or patients with atypical migraine, even if they're having neurologic symptoms, because the neurologic symptoms are fluctuating. True pathologic neurologic symptoms are progressive and unremitting. So we have, of course, new CGR receptor and CGRP ligand antibodies that we inject monthly. Those can be very helpful for very many people. And then we have abortive medications called GPANs, which are small molecule receptor antagonists for CGRP receptors that are really useful. And you can use them on top of traditional preventives, but they're so new that payment isn't worked out for all of these medicines yet. So when we treat chronic migraine, we like to try to move from constant symptoms to intermittent, and sometimes we have to break a constant cycle by using Botox or nerve blocks, in particular a sphenopalatine block. So Botox is injected using a preempt research evaluating migraine prophylaxis therapy, a protocol. It's 155 units in 31 sites. 7 in the front, 4 in the frontalis, 1 in each corrugator supercilii, 1 in the procerus, 4 in each temple, 3 in each occipitalis muscle, 2 in each splenius capitis, and 3 in each trapezius muscles. This is repeated every 3 months. This targets acetylcholine receptors in the muscles, but we now know that this targets the vanilloid receptor directly and prevents the action of CGRP on them. So you can inject it even in sites where there are no muscles and the patient reports pain. Sometimes we do blocks. The patients come in and we will block the supraorbital, supratrochlear, auriculotemporal, the zygomaticotemporal, and the occipital nerves with a total of 12 cc's of lidocaine or marcaine. And these superficial landmarks are easy to follow to numb these. The patients go home with a helmet of numbness. The block may wear off in 3 hours, but their pain may be reduced for days because of the central sensitization that has been allowed to run down. And then it takes time for nociceptor activity to accumulate and for sensitization to begin again. So in some patients, you can break a continuous headache and make it intermittent using these blocks, which you can repeat every week or 2 weeks according to how well patients respond. Sphenopalatine blocks are amazingly effective. If a patient comes in, you can drip 1.5 cc's of 2% lidocaine into their nose, 0.75 cc's on each side, by putting just a simple angiocath up under their nasal dorsum and allowing it to drip over the middle turbinate and onto the face of the sphenoid and over the sphenoethmoid recess. This will take away a migraine headache within minutes. The patient lies supine, and if it works, you can give them a 4% lidocaine in a Flonase spray bottle. These metered spray bottles are standard. They allow 0.1 cc per spray, and we have a compounding pharmacy mix that up for us. And they can do it at home for themselves as an abortive therapy that works in minutes. I have a lot of professionals who use this, and they say it's a lifesaver because they don't want to wait an hour for a triptan to work. So we've covered a lot of material. We've established that migraine is a common clinical problem and that there are defined neurovascular mechanisms responsible for symptom generation. We know that otolaryngologists are encountering many of these patients with atypical presentations of migraine in their clinics. And we believe that otolaryngologists should be comfortable initiating migraine therapy. So yes, we should treat migraine. There are so many undiagnosed, misdiagnosed, and ineffectively treated patients that otolaryngologists can make a great contribution by becoming familiar with migraine management to augment their ability to treat those patients who come under their care. If you want more information, this is in your handout, these books, Heal Your Headache, the 1-2-3 program, talks about thresholds and diet. Headache management with medications. This is a good pocket manual to help you feel comfortable. And if you want to hear all of the, if you want to find out that what we've talked about today scratches the surface of the possibilities of treatment of migraine, then buy this book by Oliver Sacks called Migraine. So also there's 6.5 hours of CME offered for free at MyCME called the Migraine Toolbox. I would encourage you to go there. This is sponsored by the Association of Migraine Disorders. So also, if you want to come and get your hands wet with this, you can come to my clinic for 2 days. We'll give you a 2-hour lecture reviewing this information, and you'll see how these are used. It's free in Wilmington, Delaware, and you can email me at this address. Also, there is a mentor program through the Academy, and we could confer by telephone on migraine patients over a period of time until you're comfortable. So you can look that up on ENT Connect. We thank you very much for your attention and hope that you'll put this information to good use. Bye-bye.